All right, now I'd like to welcome to the show Vance Ginn, president of Ginn Economic Consulting, staff economist at Americans for Tax Reform, and co-author of the recently published book Empower Patients: Two Doctors Cure for Healthcare. And Vance was also our guest for episode 21 back in May 2023. So let me say welcome back to Free the Economy, Vance.
Hey, thanks, Richard. It's a pleasure to be with you, and I'm just excited about the work you've been doing with this podcast since then. Just had some great guests and always doing great work. So thank you for what you're doing, Richard.
Yeah, thanks very much. We're looking forward to our 150th episode anniversary coming up. So the subtitle of this new book, the book is about healthcare policy and healthcare reform. So the subtitle refers to two doctors, right? So that's you, PhD economist, and your co-author Dean Waldman, MD. Tell us how the two of you came to collaborate and work on this project.
Well, it started about a decade ago. We both worked at the Texas Public Policy Foundation, was where I got my kind of career start in the policy world. And he had worked at the University of Chicago and Harvard, and then was in New Mexico. And he's a pediatric cardiologist. Dr. Dean Waldman, and we were both working in policy areas in Texas, but also across the country on some things, the Texas Public Policy Foundation about a decade ago. And then we started researching more into Medicaid and the excessive money that's being spent and the waste that's in the program in Texas and in other states. And then we started looking into how else can we bring together patients and doctors instead of this system of third-party payers then. Over time, we kept building on that. He left TPPF, and then I worked at the White House for a year, and then came back to TPPF. And about a couple of years ago, he reached out to me and he was like, "Hey, Vance, how's it going?" And we learned that he was still working on this area, and we started working on it together, and just continue to find ways that not only identify more of what the problem is in healthcare, but how can we, solve it in some capacity, and it really by getting government out of the way. And went through and wrote a paper, the Empower Patients Initiative, that's published by the Americans for Tax Reform, and then put this book together that we hope is more for a general audience, where anybody can read it, understand it. There's some good stories in there to help relate with the audience as well. To really, not only, Richard, because in general, healthcare is almost $5 trillion is how much we're spending per year. So it's massive. But how can we drill it down to the average American who can read it, understand a little bit about it, and hopefully help to persuade, their politicians one day that we need major reforms? Because if not, we're going to continue to have worse care, higher cost, and ultimately a worse civilization of people in our healthcare, if not.
Right. So, healthcare in America is a controversial area, and it's provided the U.S., we've got plenty of critics from the left side, from the right side. People worry about costs and access and innovation. But you and Dr. Wellman have one kind of really big recommendation that then has lots of implications, which is, as you mentioned, eliminating third-party payment and trying to make healthcare more like the sort of normal goods and services we buy all the time, which is the person who wants the thing pays for the thing, rather than having both the government and insurance companies finagled in there. Why is that one change so powerful?
Well, in your pointing this out there, Richard, is that in normal voluntary transactions that we have on a day-to-day exchange, whether it's buying a Snickers bar, which I love, or gasoline or other things, it's you and the person that's selling it. That's where market comes in, and where economics is really about, is the study of human action and our interaction to satisfy our desires within institutions given scarce resources. And typically that's done through the pricing mechanism, right? It's a market process that gets these prices to where consumers and suppliers come together in this marketplace, and they both mutually benefit or they don't exchange. And that's how most areas of our economy and our lives work on things that we want. But it doesn't work that way in healthcare. It doesn't work that way much in education and some other areas too. But sticking with healthcare here, we have these third parties that are really driving a lot of the market. And the big one, of course, is government. We have Medicare, we have Medicaid, there's rural hospitals that are run by more local governments, but also funded by the state. There's just all these other payment systems in the marketplace in healthcare that creates a distortion between the patient and the doctor to be able to come together to voluntary transact together. The other thing, though, is private insurance. I don't have anything against private insurance. If people want it, then they should go out and get it. That's why there's a market for it. And even before Obamacare and other things that have kind of forced people to getting insurance, but that force, that aggression by government, forcing in the place of whether it be directly from some of these programs like Medicare and Medicaid of getting into the market by government, meaning the taxpayer because the government has no money, or by forcing us to buy private health insurance, that can also create that problem. And then there's another problem with all this, though, Richard, is back in the 1940s, we had price and wage controls during the Great Depression, World War II, and part of that process, or during that time, I should say, is employers were trying to find another way in order to incentivize people to not only work where they were working, but incentivize them maybe to be more productive. So they couldn't raise wages. So what did they do instead? They gave them more fringe benefits, especially private health insurance. And so what this did was they created an employer-sponsored tax credit where basically your employer will get a tax credit for giving you health insurance. And so that incentivized them to do so. And we're still running on this 80 years later to where there's this incentive that's in place for your private employer to give you health insurance versus you buying it on your own. And on average now, that's about $24,000 a year per family, per household, that's receiving this benefit, this tax credit from the employer. And one of the big areas that we hope would be a good step in the right direction is get rid of that employer-sponsored tax credit and instead give it directly to the people, give it to the households, and allow them to get a no-limit HSA to where they can put as much money they want in there for health-related expenditures. And then that would allow for them to make those voluntary transactions based on their marginal cost and marginal benefits versus being forced on them by government and by the employers. And two, Richard, with everybody moving a lot more today from job to job or even state to state, it gives it more of a portability if the money is then with the individual and not being distorted by the employer. So the big part here is to find ways to get the government out of the way as much as possible, but also change the incentives such that it's not on the employer, the back of the employer, which is just coming out of our money in a different, of our hard-earned dollars in a different way, but actually having it to where the individuals can make those decisions instead.
Yeah, I know the question of portability of benefits is a big thing. We had the Mercatus Center economist Leah Palikashvili with us in a previous episode, and she talked about how it would be a really good thing for American workers in general, including, like in her case, moms who want to go in and out of the workforce based on their family structure, not to have to worry about losing their health coverage every time they stop being a full-time employee. The kind of consumer-driven reforms you're talking about and portability of health coverage in general would help that a lot. Would let people sort of follow their passion, do their side hustles, start their own small business without having to worry that they would have no health coverage at all if they leave that one safe W-2 job. And I think some people who might hear this and they say, well, we've got, healthcare, paid for, structured in one way where it comes out of your benefits and your employer pays for it because they get the tax treatment. And if we change that system, then you would get more money, but then you would also have to pay for your own coverage. So, maybe is it just six of one, half dozen of the other? But the question of how much additional cost is created by these third parties, I think is really important. And there's a fascinating chart in the book. It's in the form of if people are familiar with the Sankey diagram, it starts on the left and it has all the components of a group, and then it sort of splits them out, and it has sort of little arrows that go up and down and left and right. And you see, by the time you get to the right side of the diagram, you have whatever is left from what's been split off from the total. And so this shows all the money that in this particular chart was spent on Medicaid. And so on the left is the whole amount, billions of dollars, the tax dollars. And then as you move to the right, you see little segments split off the total. So you've got categories for administrators and money for consultants and money for compliance officers and money for lawyers until you get to the end and the total is dwindled to a tiny, tiny, thin little section. And that alarmingly tiny section is the amount of money that's left for actual healthcare providers and for doctors and nurses to help you. And it is, like, as I alluded to, it's alarmingly small by the time
Yeah.
you get to the end of it. So, one, we maybe already know the answer to this question, but do you think most Americans know how little of this total healthcare spending actually gets to treating people rather than paperwork and overhead? Do you think we'd change their mind if they didn't know that?
I think they would change their mind, Richard. I mean, when I talk to folks about this, they don't. I mean, I think they do believe that most of that money is going to doctors for actual health care. And instead, it's going to the system. Our best estimates is that it's about half of the $4.8 trillion a year that's spent in healthcare across the economy, not just by government, by the private sector and everything, right? About half of that is actually going to what we call burden, Burrden, an acronym, which is basically just the bureaucratic regulation and costly paperwork that's done throughout the system that's really put in place by government and by private health insurance to meet the reimbursement rates and everything else. So let's say it's 50%, that means $2.4 trillion is not going to health care. And one of the issues with that then is that it leads to not only the people not really know how much is going to healthcare, and they'll say, well, why do we spend so much on healthcare? Well, a big part of that is going to this burden. It's going to regulation and other things. It's not going to the doctor and the nurses to actually get us quality care. And what that's leading to then is longer wait times, not as good of outcomes as we otherwise could see, because it's not going to the healthcare. It's going to the things behind the scenes, if you will, for the paper pushing and regulations that's happening. And unfortunately, that means we have people who, what we call death by queue, where they get in line, especially on things like Medicaid, where it's difficult to find a doctor who's even going to take your the Medicaid, right? This government provided health insurance. In Texas, Richard, where I live, only about half of doctors take new Medicaid patients. So if you're already going to wait in line, you can't find a doctor around, then what we're seeing is that people have actually died waiting for care because of the bureaucratic nightmare that we call the healthcare system in the United States. And I'm hopeful that with our work and this book and other work that's out there, I mean, I think there's a lot of good research in the healthcare space that's been done. We're trying to build on that and make sure that we can find the best market-based healthcare system possible. That way we can, improve outcomes, reduce and hopefully eliminate this death by queue sort of idea. And ultimately, Richard, look, the federal government is running about $2 trillion a year in deficits. The national debt is $37 trillion. One of some of the major drivers of that increases in the debt and deficits per year is coming from Medicare. You also have Social Security, right? So that's another issue that needs to be taken care of. And these, for too long, have been off the table. I remember whenever I was working the Trump administration during the first Trump administration, basically the president was like, look, we're not going to touch these. And there has been a little bit of touching of that in the second administration, especially Medicaid. I'm not so sure they'll do much with Medicare, but Medicaid, at least there were some work requirements that helped slow down the growth rate over time. But these have been politically off the table. And I think to your question, though, which is a great one, is how much do people really understand about this? I don't think they know that $2.4 trillion is being wasted. And if they did, I'm hopeful that that could also change up some of the political discussion around it, because we've got to get this fiscal house in order, or we're going to continue to have economic slowdowns, other types of crises that are higher interest rates, higher inflation, because they'll just monetize that amount of debt. And so it all goes in together with my more fiscal background, but to really try to drive into the huge cost that is health care, the system, not health care, the actual care that we're receiving.
Right. So what does a better system look like? So when I'm going through the book and I'm seeing like the major elements, which is getting rid of the tax treatment for employer supplied healthcare. So instead of your employer spending $25,000 a year to buy you healthcare, they can pay you $25,000 a year and you can buy your own healthcare.
Yes.
Establishing sort of mega health savings accounts. So a lot of people have know in general the idea that an HSA, health savings account, is a tax-free way to save money for healthcare expenses. And we could sort of mega size that in various ways to make them more accessible, get rid of the current contribution limits and things. Um, and then at the same time, people would say, well, if you want to like do major reforms of Medicaid, which is sort of Medicare is the government benefits for older and retired people, Medicaid for low income individuals and families. If you can't really change Medicaid, people would say, because well these poor people can't afford healthcare coverage on their own, so they'd be left out in the cold, and either they'd get no treatment at all, or hospitals would just have to eat the cost of it. But in the book, you mentioned that you could certainly have government funded HSAs, right? So you would have support for people who couldn't afford any coverage themselves, but they would still be able to spend their own benefit money and economize and make choices on their own in a way that they can't now. Like you said, having the kind of Medicaid bureaucracy set all the rules means most doctors won't take those patients, whereas if they were spending their own money like any other patient, that wouldn't be an issue. So
Yeah.
are those the main elements?
Yeah, you hit it on the nail on the head, Richard. I think that's a great way to put it. The employer-sponsored health insurance, let's give that instead of to the worker or the employer, let's give it to the worker, the individual. Let's also look at block grants to states. I think that's the other big key component here, which has been kind of in the conservative movement, libertarian movement, and stuff like that. That's been out there for a while. Is let's block grant these things to the states, get the federal government out as much as possible with as few strings attached.
I remember Newt Gingrich talking about
Yeah.
that. That was the big, that's like a big 1994 Back to the Future, block grants to the states.
Yeah, exactly. And I think we should bring that back. I mean, that would be a great avenue to go down. It would not only save money from the federal level, meaning us, the taxpayer, paying for it, but we could also use it to have flexibility among the states. What Dr. Dean and I have talked about is, California and Texas, where I live, are likely to have different ideas of what the healthcare system should look like and what the role is for government, right? And in a system of federalism, which I think is one of the most remarkable things about America, is our system of federalism, is that we should allow for this laboratory of competition to see what works and what doesn't. My view would be that a single payer where the government has more control is not where we want. I want more of a single payer to where the patient is in control, the individual is in control. And I think maybe Texas does that versus California. Let's see what works. But let's stop this whole idea of we're going to continue to force people to get health insurance and we're going to provide it to the employer and not the employee. All these things create more problems in the healthcare system. And the more that we can have the doctor and patient. Well, one other thing here, Richard, is when we go to the doctor today, I've got private health insurance now, but it oftentimes still seems like they're trying to push me in and out a little bit. Maybe I need to get a new doctor or something, but there is kind of this in the system. And that's the way they get paid overall, is because the reimbursement rates and everything else. Well, what happens when we actually have doctors and patients being able to come together? You see this a lot right now in direct primary care, DPC model, where the doctor actually really seems to care a lot about their patients and can spend as much time with them as they want and things of that nature. That may be a better method or an institutional construct, if you will, where it brings together the doctor and the patient for us to get the best outcomes possible. And so, but through this area of experimentation and allowing for people to have their own money on where they're going to spend those dollars through a no limit HSA, I think that would really change the dynamics and the incentives in the healthcare industry to where we have better care overall.
Well, yeah, you mentioned the sort of the laboratory of the states federalist view, which is if we give states more freedom, we can compare the outcomes. What happens? We've had some states like Vermont tried to set up sort of its own kind of universal healthcare system. Didn't quite work. It was like way too expensive, and so it doesn't exist anymore. That's the problem with government policies and government agencies is that they're generally not allowed to go out of business even when they fail. That's one that's that did go by the wayside. So we have the great potential to compare outcomes when we have 50 state systems, but obviously we also have lots of international systems.
Yeah.
And that the phrase used earlier, death by queue. So queue meaning to line up, but queue is not really a term that's used a lot in the United States. It's used more in the United Kingdom. And of course, that's where that term death by queue came from because the UK has the National Health Service, which is the single payer national program. And it's something that a lot of left of center people, progressive people in the United States seem to think is great because it's this, universal kind of zero marginal cost, uh, not zero cost to taxpayers, obviously, but
Yeah.
zero cost to sort of see a physician each time. But it's created terrible inequities in people who have not been able to access the care that they're supposedly entitled to, and so how what sort of inspiration, positive or negative, have you taken from the international systems you've seen? Again, in the book you mentioned the UK and Canada. Um, what does the international scene look like to you?
Yeah, I think you put that well there, Richard. I mean, there's this dichotomy really of where I would like to see the future of more kind of a free market capitalist sort of healthcare system versus the government dominated system. And I should mention that even in the United States, about 60 cents of every dollar is spent by government, meaning us, the taxpayer. So it's a government dominated system. But if you look at places like Canada that you mentioned, nationalized healthcare there, or in the UK, nationalized healthcare there, some people want to point us in that direction and say, look, it's going to be cheaper because on average they spend less than we do per capita and things of that nature. But we also have to look at the outcomes. So for one, they pay much higher tax rates than we do to pay for those higher costs and on those spending areas, at least from the government part of things. But also, you have to wait longer in line. And so oftentimes what we see in places like Canada and the UK and others that have a nationalized, a socialist, what I consider a socialist healthcare system, is that they have a robust underground private market. And not all of it's underground. There are some, but you have to pay more out of your own pocket in order to get that care. If you really want to get timely care, especially for surgeries, those you have to wait a lot longer in line if you're going to go through the nationalized healthcare market. And a lot of people from Canada, in particular, will come to the United States to get access to care here much faster if they need something to deal with cancer, a lot of the major diseases and other things that are out there that they just can't get access to as quickly in Canada as the United States. And I think that's a big part of this that we need to look at. It's not just the cost, it's also about the amount of care that we're getting, that we're receiving. And in America, for the most part, you can get pretty timely care, unless you're on Medicaid. It may take a little while longer. But if you have private insurance, I can call today and probably get a doctor appointment tomorrow or maybe even the next day. But in many other places in the world, that's not the case. And I just want to reiterate that those places that have this socialist system still have a private system outside of that to where many people are using. So they're paying not only in their taxes, but then they're also paying again through the private market.
Right. So one of the reasons that a system like the UK system sort of works is that it has the steam valve where if the NHS doesn't give you what you need, it's at least theoretically possible to get your coverage someplace else,
Yes.
to get your treatment someplace else. And if you're in Canada, you can come to the US. Uh, you know, uh, so your co-author mentions an anecdote of an elderly woman who broke her hip, and
Mm.
the NHS said, "Oh, well, we can get you into for a hip replacement in 48 months," right? Which
Yeah.
which is insanity, right?
Mm.
Um, and something that would for all the deficiencies we have here would not happen in the U.S. Um, and so there's, I think, a pretty clear argument that even though we may be better than some elements of the UK and Canada system, that we have a lot of room for improvement in the US. And, ever since the, Affordable Care Act passed, aka Obamacare, back in 2010, Republicans at the national level have been focused on repealing it during sort of the Tea Party era, the early 2010s. That was perhaps one of the single most common things was we need to repeal Obamacare. Um, Practically all the House Republicans talked about for a while. And uh, since then, Republicans in Congress, especially in Congress, but at the national level, have taken a lot of criticism for not having a sufficiently clear, robust replacement strategy, right?
Mm.
Um, because a lot of people said, well, if you repeal Obamacare, then we go back to what was before, and that wasn't great either. Uh, and there hasn't been, in my humble opinion, uh, really robust leadership at the national level saying, well, okay, well, we don't like the Affordable Care Act and Obamacare. We think that's flawed for various reasons, but here's the much better thing. Uh, I think the Plan and Empower Patients is probably pretty close to that much better thing. But why have people who are not in favor of more government takeover healthcare not been able to do a better job, other than you and me,
Yeah.
in arguing for this sort of major healthcare reform?
Yeah. I mean, part of it is political. I mean, you're right. That whole wave of the Tea Party, 2010, 2011, and so forth. I mean, there was a big push to stop Obamacare because it really didn't go into effect until what, 2014, I believe it was. So it was a few years later. So there was some push to try to either push that out or to stop it. They weren't able to. There was some talk even in the first Trump administration when he first came in, right? There was a big push by Congress then to do something. They couldn't do it then. It was down basically to one vote, Senator McCain, to making some changes there at the time. But regardless, there has been this push to not do anything with Medicaid or Medicare, and it's politically. They don't want to. They can't win a re-election. I think is a big part of it. Rent seeking, James Buchanan, right? Public choice economics, where you need to get reelected, and it really keeps them from doing something with this. I think there's also something to this of because it really is a bipartisan problem from the Democrats and the Republicans, to where I think Republicans have been enjoying giving tax cuts, but haven't really wanted to cut spending. Even with the one big beautiful bill, the spending wasn't cut. It was just slowed. I mean, DC talk is there was a cut, but that's just because they're spending less than they otherwise would, right? But yet they were able to extend some of these tax cuts and give out, tax favorability to those with tips. Or overtime pay and all this stuff. And so there's handouts on one side, but then there's also got to be handouts on the other side. And I look forward to the day when people will really understand that our quote unquote debt crisis is really a spending crisis. And when we can understand that this is a spending crisis, it will hopefully force us to make tough decisions on the spending side, mainly being in healthcare related programs. But to your other point, though, I think which is a good one, is I don't know that we've been creative enough to put forward the ideas of allowing for a more free market based healthcare system. I don't know if we're a little too tentative or whatever, but that's what Dr. Dean and I are trying to do in this book, is put together some of these good ideas that are out there. I mean, there's a lot of great folks, Brian Blaze and Michael Cannon, and a number of people that have been working on healthcare, is trying to put this all together and say there is a plan out there for us to get to. We may not get everything that we want, but this is the direction of where we need to be, getting government out of healthcare as much as possible, and also allowing for states to have flexibility if we're going to have a role for government. Richard, one of the things that I kind of, because I'm more libertarian overall, as you know, more classical liberal, and so I don't know how much of a role government should even have in healthcare. I think it's something that we should consider. I think that my dad had epilepsy, so he was disabled. He was not going to have any other ability to get a job because he was having seizures, pretty often. And so for that sort of situation, I would like to first turn to charity and families and churches, synagogues, that sort of thing. I think civil society is really where we should turn first. But too often we're making government the first line of defense. And I think by what we're hoping to do is put government back to where I think it should be, is more at the back of the line, to say if there are going to be roles for government, they should be limited, and we should be doing them in a way where the money is actually going to the people we're trying to help, not half of it going to bureaucracy and bloat and everything else. And I think when we start to change this mindset and re-envision the wording and how we're going about it, of where we want to be, we'll be in a much better position, I hope, politically, to where, that's another key thing, Richard, is that in education, it's also dominated by government. And for many decades, it was difficult for politicians to talk about school choice because the school boards and everyone else would come out against them, and the teachers unions and everything else. Well, we've seen the school choice revolution starting to happen now, and things are opening up.
Oh, yeah.
Well, maybe we could have that with healthcare one day.
Yeah, and I think you see an analogous thing where if you look at a chart of spending for the past, say, 50 years on public education in the United States, you see the spending, everything is adjusted for inflation. You see the spending on classroom teachers, and it's almost flat. you see the spending on administrators and non-classroom teachers, and it's exploded by a factor of like 10. Right?
Yes.
So
Yes.
that's sort of similar to all the money that's going to administration now in government healthcare
And,
policies.
and Richard, I wonder, right, if that's just part of the beast, the belly of the beast, is that government wants to grow itself. How do you grow yourself? By hiring more people, giving yourselves wage increases, and things of that nature. So it's almost like this self-fulfilling prophecy to where we create this beast and then it just keeps growing.
Hmm. So, you know, I think, any health policy reform is going to be, need to be focused on, like you said, patient outcomes first and
Yeah.
foremost. And there's definitely ways to measure that. But one interesting angle I thought that I hadn't really thought that much about from the book is Dr. Wolman's point about how burdensome the current system is on doctors. One, in an obvious, work hours way, they have to spend a lot of money or spend a lot of time filling out paperwork and worrying about which drugs they're allowed to prescribe because of certain formulas. But he also describes that the current system makes their doing their job sort of difficult or impossible in terms of just providing the best healthcare to patients and connecting with patients, being able to spend enough time with patients. And so, he says most of, certainly being an MD, maybe not quite so much with some of the other healthcare roles, can be a fairly prestigious job. But the vast majority of doctors do not go into that, and they don't spend, 12 years in school because they want to become multimillionaires. They do it because they want to like heal and help people. And the current system makes it so difficult and sort of dispiriting that a lot of doctors don't even want to stay in the profession, right? Because they feel like they're pouring their whole life into doing this thing, and they can't make the difference they want to make. So I think that's a kind of, and of course, if you've got low morale of doctors, that's going to translate at the end of the day to probably worse patient outcomes as well. So it's sort of circular in that sense. But I think that just the morale of the people who work in the healthcare industry is kind of an angle of this we don't hardly even talk about.
Yeah, no, yeah, it's a great point, and that's one reason why Dr. Dean, like I said, he was one of the top people at the University of Chicago medical school there, and their medical department and their hospital, and other places. And this paperwork, this burden was put on him of not being able to help out these kids that had heart problems because he had to do all these other things, is what forced him into the policy world. He said, okay, I can't make the changes that I want here as a medical doctor because the system is broken. And so let's do some systems analysis, which we talk about in the book. And that's what got him going into the policy space. And I think he's onto something here whenever you see this. And one other thing to think about is we talked a lot about the demand, right? Like the subsidies and Medicaid. And so we push demand, but the supply is also being restricted, whether that be the FDA on drugs and how many new drugs are coming out, which Right to Try, I think, is a good step in the right direction, and some other things that are there. But also the amount of occupational licensing, right? The scope of practice for nurse practitioners to not do their full scope of practice of what they've learned reduces the supply. And the amount of telehealth is really starting to advance. And I think that will also help to expand the supply. So these are the sort of things that I think if we can help to get rid of some of the artificial subsidization of healthcare that's driving up the demand, while at the same time restricting the supply, and allow for more supply, then we would have more market prices, a better market process that would allow for prices to come down in healthcare, while, to your key point earlier, we got to make sure that the outcomes are improving. And I think that's where it is synonymous with what's going on in education, that you're right to point out, is we've been spending a lot more money in education, but the test scores for students keep going down. Teacher pay is flat in many places. I think the best teachers should get paid more. The best doctors should get paid more. The best nurse practitioners should be able to do their job. And so what it is really a failure of government. It's not market failure. These are government failures. Whenever you try to solve these with more government, you double down on the problems instead of allowing for the market, voluntary exchanges to really come in. And I think it's tough for some people, though, Richard, with healthcare as something as we talk about this too, where healthcare isn't a right. You have the right to obtain healthcare. But as soon as you start saying you have a right to healthcare, you're then saying you have the right to obtaining the services from people, whether they get paid or not.
Mm.
You have the right to those things, and that can then also be taken away. As soon as government says you have a right to it, they can take it away. And so this all creates more of a problem, and is one reason why we should be getting government out of the system and get rid of these third parties as much as possible to get back to that doctor and patient relationship to empower patients.
All right, fantastic. That sounds like a plan. Well, Vance, thank you so much for being with us again. Two Timers Club on Free the Economy. And before we go, please tell everyone where they can find all of your stuff online. It's all excellent content.
Well, thanks, Richard. As always, keep up the great work on Free the Economy. My podcast is called the Let People Prosper Show, where I talk about these issues and a lot more. It's on all the major platforms. But just go to vanceginn.com, vanceginn.com. Easy. You have my Substack newsletter and information on healthcare and a whole bunch of other stuff that I'm working on. But this book, I hope, will continue to change the dialogue, to define the narrative about where we need to be in healthcare and ultimately empower patients. So thanks again, Richard.
All right. Thank you, Vance.